Good evening, ladies and gentlemen. In case there's any here who don't know me, I'm Dean Royce. I'm Dean University of Otago, Christchurch. And it's my pleasure to chair the series of public lectures. This is the 6th in a series of 8 lectures that we're doing this year. It's my great pleasure tonight to introduce Professor David Murdoch. David, like many of us, was a medical student through here a few years back. He did his initial training in pathology, microbiology, and other early work as a resident medical officer in Christchurch. He then did further training in tropical health, infectious diseases, microbiology at Liverpool and at Duke University in the United States. In 2002, David was appointed by the university to be Professor and Head of our Department of Pathology in Christchurch, and David's done an excellent job in that role over the last 14 years. Tonight he's going to talk about One Health, a global approach to tackling infectious diseases. I'm sure David will give you a better background than I can hand over to David. Thank you.
Thank you, Peter. And is the sound okay? You can hear me? Well, thank you for coming along tonight, and thanks for that introduction, Peter. The talk I'm going to give tonight is on a topic called One Health, which I expect that virtually no one in this audience, or very few people actually, will know what One Health is, but most of you will not know what One Health is. And I will, in the talk, explain what One Health is, which is a relatively new approach to how to tackle particularly infectious diseases, and then tell you a little bit about what we are doing in New Zealand at the moment with a One Health initiative. But I thought before I define One Health, I would just tell you a small story that will illustrate a lot of the aspects of One Health. And I'll take you back about 15 years, and this is Kathmandu in Nepal, where I've had a long association. Back then, in 2001, some colleagues and I were involved in a research project that was based in one of the main hospitals. This is the hospital here, it's called Putnam Hospital. It's one of about 3 large general hospitals in the Kathmandu Valley, with Kathmandu being the capital of Nepal. And the project was a relatively simple one. This is a country that has a heavy burden of infectious diseases. It's also a very poor country. And although there was great awareness of infectious diseases, the ability of the hospital staff to actually diagnose those infections and know what were the key infections, what was the burden of those infections, it was fairly limited just because of the lack of resources. And so the project we did was a very simple one. It was still called the fever study. That was what it was called at the time. People still refer to it as the fever study, which actually became quite a sentinel study in Nepal. And all we did was, for a period of time, each adult admitted to hospital with fever. Fever is one of the main symptoms of infectious diseases. What we would do is we'd run a battery of tests. And these were tests that wouldn't normally have been available. There were simple blood tests and a variety of other tests. And we found a few things that weren't a surprise. We found a huge burden of typhoid fever, and Kathmandu then, and probably still is, the world capital of typhoid. So we really confirmed that as a major disease. Pneumonia was common. But one of the surprises was we found typhus to be very common, very similar name to typhoid, but typhus. And some of you may have heard of typhus. Typhus is, it's actually a group of infections caused by a very small bacterium called rickettsia. And this one was called murine typhus. Murine refers to mice. And this was something that we hadn't, although we tested for, we thought it might be there, we hadn't actually expected it to be so common. And this is an infection that causes fever and headache and sometimes rash, and sometimes can be very severe. And it requires particular antibiotics to treat it. So that was a major finding, and in fact, ever since, this is one of the impacts of that study was that the clinicians are aware of typhus and they think about it, and they often will treat patients thinking about typhus. But to actually really understand the disease and perhaps get a better idea about who would be at risk of typhus, who was, perhaps how to prevent it. We need more information. In fact, some of our own data showed that it was particularly common in winter, and it was particularly common in certain parts of the city. And we also know a few things about typhus. We know it's linked to, and this is a rat on the streets of Kathmandu. We know it's linked to rats, so contact with rats, and in fact it's transmitted from rats to humans by fleas. And so that's the connection, and that's been known, that was recognised for a long time. And so people are at risk of nearing typhus when they are in an environment where they're exposed to rodents. And of course, we think of those sorts of environments, and I'm sure some of you here have been to Kathmandu, a very typical photograph of the very crowded housing conditions in a very poor country, poor living conditions, a place where rodent infestation would be expected. And so in a way we hadn't thought about nearing typhus, so it's wrong, but this is actually a very obvious place for us. So here we had a situation of disease linked to rodents and fleas and this environmental aspect. So we're really with three aspects. The human side, which we tend to focus most of our attention on, but there's clearly an element that was important to rodents and the environment, and if we were to think about how we might want to prevent the disease, there are obviously other ways we might want to do it other than focusing on the humans, maybe rodent control, maybe improving the housing things. And this is really the core of One Health, the idea that you really can't understand, particularly infectious diseases properly, without having this global view that looks at animals, that looks at the environment. And so in fact these are the three components that form the triad of One Health. And this is actually the diagram that we more commonly see, which shows that triad, the humans, the non-human animals, and the environment. And there are many definitions of One Health, but it's usually on the basis that the health of humans, animals, and viability of ecosystems are very much linked, and in fact inextricably linked. And here's another definition, the One Health concept. One Health is dedicated to improving the lives of all species, human and animal, through the integration of human medicine, veterinary medicine, and environmental science. So it's really getting people together, the human health people, the animal health people, the environmental science people, to help solve some of these issues that relate to human and animal health. And in a way it's kind of obvious, and the elephant in the room. It is a really obvious concept, but in human health, we've been really, really slow to take this on. The vets have led the way. They've really pushed this. They understand that. Talk to any vet, they know what One Health is. Talk to most doctors, they don't know what One Health is. And in a way, it is a very obvious approach to tackling, particularly infectious diseases, but not totally. And there are many organisations in the world working on One Health have signed up to it. So the World Health Organization, the animal equivalent, which is the World Organization for Animal Health, FAO, and there are various other initiatives. And in fact, all the major public health organisations in the world have signed up to the One Health concept, so there is a lot of activity. But as I say, this very much applies to infectious diseases. It makes total sense in the area of infectious diseases. And you may have seen this before, but this is a very famous quote from the 1960s. And this was at a time when there were a lot of antibiotics, when antibiotic resistance wasn't really a problem, and it was thought that actually we were conquering infectious diseases and they were going to go away. So this is a quote from the Surgeon General. In fact, he's famous for this quote, saying that we closed the book on infectious diseases and declared the war against pestilence won. Apparently he can't remember ever saying it, but he's famous for this quote, and this is trotted out all the time. And clearly it was just so wrong. And this next graphic is fairly complicated, but what it shows is over recent decades, the infectious diseases that have newly emerged, ones that we have never heard about before, or re-emerged, those we do know about but have reappeared in a different way or at a different intensity. And the blue there are the totally new ones. And that may be because they've been around a long time, we just haven't recognised them. But some of them clearly are completely new. The yellow are the ones that we know about that have re-emerged in different ways. And there's one there that's an aqua, which I'll just highlight there, which is anthrax, which is a deliberately emerging one, because of course in 2001 in the US, anthrax was deliberately released as an agent of bioterrorism. So there are many, the world of infectious disease, I'm not going to be without a job. And so there are lots happening, and in fact, we haven't got, this isn't up to date, we haven't got Ebola in West Africa, we haven't got Zika. I'm going to talk about those later. The other interesting thing is that most of these have a connection with animals as a reservoir or a way to transmit to humans. And that's an important point. And so I'll introduce another definition, zoonoses, and these are infections of animals that are naturally transmitted to humans. And so zoonotic diseases are infections we acquire naturally from animals. And that can occur in many ways. And don't worry too much about the names, and I'll go through some as examples later on. But this graphic here really shows the main ways that we may acquire infections from animals. One way is through the food chain, so from food we eat that is contaminated. Maybe through domestic pets, so toxoplasmosis would be one, or rabies. Not in this country, we don't have rabies. Or from wildlife, and that example I gave before of murine typhus, the wildlife were rodents in that situation. And these are some of the, but easier to read, these are some of the more well-known zoonoses. The list is actually a lot longer than that. And some you may be surprised, some will be familiar with, some you may be surprised to see is listed as a zoonosis. I guess HIV infection, you might not necessarily think that, but the origins are believed to have come from non-human primates in Africa and a variety of that virus. And I'm going to go through some of these just to give you an illustration of the type of zoonotic diseases, and perhaps where that One Health approach can help in terms of the way we try and tackle these diseases or understand them a lot better. I've stolen a few graphics from the Animal Medicines Australia website, and this is one where this talks about zoonoses, and the burden of zoonoses estimated at $120 billion worth. I think that's globally a year. That the burden of zoonoses, that 20% of global animal production is lost to these diseases, so it has an impact on animals, that there are many diseases that have a link, as I've already mentioned, that some are preventable, some are actually potentially able to be eradicated, and rabies would be one example. We're a long way off that, but it's possible. And the fact that the animal health industry is really very focused on trying to control these diseases. And a little bit complicated, but if you focus on the bottom line here, these are some of the more common zoonoses and where they've appeared over time. And the impression you get is that there are, by the dots in the bottom right, there are a lot more have emerged over recent years. And that may be because they're totally new, we don't know about them, or we just haven't recognised them before. But there are certainly changes in the way we live. We live in much larger populations, we can travel much more easily, and there's certainly good reasons why some of these may be more of an issue at the moment. And you won't be able to read the details, but just to give the overall sense, this is the list of notifiable diseases in New Zealand. So these are diseases we have to, by law, notify to medical officers of health. And what I've done, they're mainly infections, and what I've done is highlight in yellow the proportion that have an animal link that is zoonotic. So as you can see, it's a high proportion. Difficult to gauge the burden though in the country. And these are some estimates that are widely bandied around. They may be overestimates, but they'll be roughly right. 60% of non-human infectious diseases have a source in domestic and wild animals, 75% of the emerging ones, and then potential agents of bioterrorism, the microorganisms that are used, like anthrax. Most of them are as well. So here's some examples, and I thought the obvious one people often think of as zoonotic is rabies, and this is a disease fortunately we do not have in New Zealand, but for a lot of the world this is a problem, and it's estimated that there's probably one death every 15 minutes in the world of rabies. And rabies is due to a virus that's acquired usually from the bite of an animal affected, and the animal will be sick with the disease, and for some animals they become aggressive and more likely to bite. So actually the maximum likely to transmit the disease. Once acquired, it affects the brain and is universally fatal. It's a truly mortal disease. And it is mainly dogs, it can be monkeys, in the United States it's raccoons. I've seen what I thought was a rabbit cow, not so common, but there are a variety of animals that are able to transmit it. But certainly something that major efforts around the world to control with culling of animals, with vaccination and other measures. Back home, Campylobacter infection. I suspect most of you have heard of Campylobacter. It's a bacterium that causes diarrhea. It's a foodborne disease, most commonly acquired in New Zealand. We tend to have mainly as from untreated milk, but more commonly in New Zealand from undercooked poultry. And that link is fairly well established. This shows that link. And there was I guess a good illustration of the collaboration between a variety of professions, human health people, animal health people, environmental scientists, to actually address this problem in New Zealand, because it was noted particularly through the 2000s that there was an increase in incidence of Campylobacter infection in New Zealand. And there was discussion about why this might happen, and good evidence that it might be linked to undercooked poultry. Poultry is very frequent, a very high proportion of poultry, fresh poultry, is contaminated with Campylobacter. Chickens carry it in their gut, and in the process of slaughter and preparation, the meat very commonly gets contaminated. And so there were efforts, and this got very political, and there were efforts there. I think some key figures here: Michael Baker from University of Otago in Wellington, Nigel French, who's a vet at Massey, and others were involved in this. And in the end, a variety of interventions were put in place, increasing the priority on freezing chickens, which reduces the bacteria count, amongst other things, led to a decline in cases. Salmonella, another bacterium that produces diarrheal disease, and in this case I've got a picture here of the sparrows feeding on the plate on the table. And I don't know if you remember back in 2000, there was a whole sparrow, it started with the sparrows were dying in New Zealand. There was a lot of discussion about why they were dying. And it was linked to a particular strain of Salmonella called DT160. And this was not one that we'd seen a lot of before, but since that time, the first cases were about 1998, but through the 2000s, this became a very common strain causing disease in humans and obviously also some animals throughout New Zealand. And probably the first large outbreak occurred here in Christchurch and subsequently spread throughout the country, probably through the wild birds. And hopefully this will work. Thanks to Nigel French at Massey at this graphic, which shows where the cases appeared in the country. And what I'll just explain for a start before I turn it on. These are various strains of Salmonella. The blue and the purple dots, these are just where the cases appear over time. Blue and the purple are some of the more common ones that we would see at the time. The blue one was particularly associated with contact with sheep, and the purple one associated with beef. And so these are human cases. The green ones are the ones associated with this strain of DT160. And what you'll see is they'll start appearing around South Island and Christchurch and then very quickly move into the North Island. So this is over a period of about 9 years. So you'll see it now suddenly in South and then moving through to the North. And then we're now in 2003, so it's 3 years into it. And over time, still see a much smaller number, but the persistence of cases, particularly in the North Island. And that was probably spread with the sparrows. Another zoonotic infection that is particularly common in New Zealand is leptospirosis, quite a different infection. This is actually the commonest occupationally acquired infection in New Zealand. And it's caused by these bacteria called leptospira, and you can see them on the right. There's a whole lot of them. They're spiral-shaped bacteria. And they cause a disease that can be very severe. It's characterized by fever, by headache, by rash. It can have quite marked complications. And in fact, this is of how you get leptospirosis in most parts of the world. It's usually linked to rodents, and who will have who will excrete the bacteria in the urine. And so it's places where the exposure to rodent urine. So it's often in fairly poor environments. It's also the disease that occasionally an elite athlete, Steve Gurney, got in an adventure race in Malaysia when he was crawling through caves that were presumably contaminated with rat urine. But actually the situation in New Zealand is very different. And it's an occupational disease. It's associated particularly with freezing workers and with farmers. And so the freezing workers are exposed to particularly the kidneys or urine in the slaughterhouse. And if they get presumably through a cut or onto them through their eyes, they can acquire the infection. Of course, a famous New Zealand invention on the right, one of the milking shed, is perfectly designed to transmit leptospirosis, because if you think of the worker here, and if these cows decide to have a pee, which comes at about eye level, which is perfect. So it's a great environment to acquire leptospirosis. And this has been a major effort, and actually perhaps more the vets than the human health people really to try and control it. The former Department of Labour, and they can be very interested in this. It's a disease that can have a chronic fatigue type syndrome associated with it. There's certainly a lot of time off work due to it. So from the occupational side, there's a lot of interest in leptospirosis and trying to eradicate it. And although it's grossly underdiagnosed, we probably have some of the highest rates in the developed world. Influenza, another zoonotic infection that we may not think of it because we tend to acquire it from other humans, but influenza viruses tend to be maintained in the reservoirs of birds, and occasionally they transmit it to other animals, pigs in particular, and we're often exposed from the viruses from pigs, and these are often mixing vessels where the various viruses are mixed within these animals, and they often mutate and new strains appear that may cause more severe disease. They may be able to be transmitted to humans and cause outbreaks in humans. And occasionally some of them can be the bird ones can be directly transmitted to humans. Unfortunately, we haven't seen outbreaks that have been too big. There have been some reasonably locally big outbreaks where they've often caused quite severe disease, but these new strains that appear have been the focus of a lot of attention and concern about new pandemics that will sweep the world. There's a lot of concern about influenza, but there are other respiratory viruses. You probably remember SARS, which stands for Severe Acute Respiratory Syndrome. It's about 2002, 2003. There was suddenly an outbreak of respiratory illness in southern China. It took a long time before they actually managed to diagnose what it was, and there was a lot of political involvement in that. It was thought that it could have been influenza, but it turned out to be this virus we call coronavirus that had not been previously described. And what was also a feature of this was how readily it was transmitted around the world with air travel. And so there was a big outbreak, in particular in Canada, but in Hong Kong, and particularly around Southeast Asia. And there were a few cases in New Zealand as well. The animal link there, the civet cat in the bottom and the horseshoe bat are thought to be important in these, particularly in South China, and their proximity to markets and humans was thought to be the origin of that, and then subsequently spread human. There's another one more recently you may or may not have heard of, which is called MERS, which is the Middle East Respiratory Syndrome virus, and it's a related virus, a coronavirus again. And this is one that's emerged out of the Middle East, and it's linked to bats again. You'll see that bats are a fairly common source of a lot of infections to humans, and a few other animals, but also camels. And in actual fact, the main transmission is probably the contact with bats and camels, and this is once it's in in humans, there is transmission from humans to humans. So again, this is one that has been transported around the world with air travel, and this is the latest graph or map showing where cases have been. We haven't had any in New Zealand yet. There have been a few suspected cases. But we're all on alert for cases from people who've been through the Middle East. I think the one particularly to note was the number of cases in Korea. And this graph at the bottom shows the number of cases over time. There's this big peak here. But this one here is cases nearly 200 cases in Korea that were imported by one traveller. And he was a businessman then in the Middle East and went through, even though there's heightened awareness, even though he's known to be in the Middle East, he slipped through there were many points where it could have been recognised that he was carrying this infection, but they were missed. And in the hospital where he eventually ended up in, the infection control was suboptimal, and there's a lot of spread within the hospital among other patients and staff. And a lot of lessons learned, and there was actually quite, the burden, the resources involved to get on top of this outbreak were quite enormous. Ebola, and of course we've heard a lot about Ebola recently, and this is another infection caused by a virus. It's one we've known about for some time, but they've tended to be relatively small outbreaks in certain parts of Africa. It's a very severe disease. It causes fever and internal bleeding and with a very high mortality, and very readily transmitted human to human. So health workers are at major risk of acquiring from treating patients. And so a lot of the photographs of Ebola, you see people with their personal protection. And of course this outbreak, the recent outbreak, actually still hasn't quite gone in West Africa. That mainly affected three countries, Guinea, Sierra Leone and Liberia. It was unprecedented in terms of its numbers. The number of cases were greater than ever any other Ebola outbreak. And as you'll see here, nearly 30,000 cases and approaching 12,000 deaths. It's a huge burden on some very poor countries with limited resources. And the ecology, what we understand, we still don't know a lot about Ebola, but we believe that it's maintained in certain forest and jungle environments, probably among bats, and then possibly spread between bats and some other primates. And so certain situations when humans are exposed to that sort of cycle is when we start to see human cases. And it's been implicated in people going hunting and association with getting bushmeat, and so a lot of these primates and bats are consumed as food, and presumably some of them are infected. And actually, the virus is probably behaving like it's always done. The big difference here is the greater populations and the increased mobility of people that has probably spread it into the major urban areas, which hadn't happened in the previous Ebola outbreaks. So you can see here, and the control of Ebola it very much relies on a multidisciplinary approach. It's been vets, doctors, environmental health people. It's a very good example of where the One Health approach is really the only way that we're going to be able to manage these sorts of outbreaks and try and prevent them happening again. Of course, I have to mention Zika. Zika is another virus, and this one's transmitted by certain mosquitoes, and it's one we've actually known about since the 40s. So in fact, if you look at the graph, it goes through 1 to 6, and 1 is where it was first described among monkeys in Uganda in 1947. And then in 1960, there were a few human cases in Nigeria, 1970s through to Asia, Micronesia, about 2007. Then we had in French Polynesia, in fact very close to us in the South Pacific. And then of course in Central and South America, ongoing outbreaks. And what we know, there seems to be the cycle, and as when it was first described, of it being transmitted among primates in certain parts of the world. Probably Africa has been a main part of that, but probably in South America as well. And then if humans encroach on that cycle, it can be transmitted. And certain mosquitoes, not every mosquito can transmit it, so it requires certain species of mosquitoes. So in fact, the distribution of this disease is very much dependent on where those mosquitoes live. They don't live in New Zealand, we don't have it here. We get maybe some important cases, but we cannot pick up, it cannot be transmitted in New Zealand because at the moment we do not have those types of mosquitoes. We have other mosquitoes, but not these ones. And in fact, this is an infection that causes fever and aches, but actually it's not a very severe infection, and we probably wouldn't have heard much about it, apart from the fact that there's concern about pregnancy, pregnant women, and that babies developing with very small heads, this microcephaly. And that has been the major concern. And that wasn't something that was recognised early on when Zika was first described, it's something more recent, and so we're still learning about it. It's generally thought to be true, but we really are waiting good data on that at the moment, so there's a huge amount of research that's ongoing at the moment to try and clarify the risks. And I thought I'd just mention one which is certainly a very personal one for me and a very local one, which has very much an environmental component. If you think of One Health, humans, animals, the environment, we tend to think often is very dominated by doctors and vets, but actually the environmental side is very important as well. And here's a disease, a very New Zealand disease, that has a very important environmental component that is vital in our understanding of disease. So Legionnaire's disease is a type of pneumonia, and the main difference is it's caused by a particular bacterium that we call Legionella. And it often causes very severe disease, and it's not actually transmitted human to human. When I say that, in fact my slide is slightly out of date because the first case of human to human transmission has just been described, but basically it's acquired from the environment. And for most of the world it's from water environments, but in New Zealand, because of the strains that we have, it's more associated with soil. And so this is it's associated with people who deal with soil, so particularly gardening. So this is a gardener's disease in New Zealand. So we see a very big peak in spring and summer as people get out into their garden. It's much more predictable, the peak in influenza every year even. So we know in Christchurch, it's particularly around November. And it's been linked to potting mix, and we're working on some studies at the moment looking at the risk factors. It confirms that association with potting mix, and it's probably certain behaviours. If you washing hands seems to be important in preventing it. And maybe one or two other factors as well, but that link with compost is very important. So here's a situation we're actually engaging with soil microbiologists and other environmental scientists, maybe actually quite useful in terms of trying to sort out how we can prevent it. This should be quite preventable. And gardening, when many people garden, very few people get Legionnaire's disease, so it's actually just trying to be able to find ways that we can prevent this severe disease happening in those few people who are engaging in this healthy activity. And this is from the Ministry of Health's Safe Gardening Handbook, so it talks about what to do with handling potting mix and trying to prevent Legionnaire's disease. I'll just mention one other thing, which is about antibiotics. So again, you've probably been hearing a lot about concerns about antibiotic resistance and the fact that a lot of the antibiotics we use rapidly are not being are now not as useful against a lot of the bacteria that cause important infections. In fact, the bacteria are winning the race at the moment in terms of the fact that we cannot keep up with the rate of resistance that's happening. That's a major concern. Enough that WHO, World Health Organization, had a World Antibiotic Awareness Week last year, and there are a number of ways that antibiotic resistance develops, and we often hear the overuse of antibiotics used to unnecessarily, the overuse, this will promote resistance and the transmission in hospitals. Well, there's also a very important animal aspect as well. There's large amounts of antibiotics have been used in farming and animal production. fact, New Zealand used to use a lot more compared to other countries. We're not nearly as bad as we used to be, but there were vast amounts of antibiotics used, both to treat problems, but also as kind of growth supplements as well. And it's not hard to imagine of animals produced for food that have been treated with antibiotics and developed antibiotic-resistant organisms, and that end up on the table. So there's another route of acquiring antibiotic resistance, and it's one that we're very much aware of. And so in addition to encouraging people to only use antibiotics when they need to, that healthcare professionals don't prescribe it when they need it, with policymakers, there's also within the agricultural sector a lot of push to minimise the use of antibiotics and only use it when necessary. Again, another example where the One Health approach is vital. And I focused on infection, but just a couple of things at the end. Non-infectious, this was pointed out to me recently, where in Scotland there was concern about domestic violence. Vets and other professionals have been trained to recognise domestic violence. So this is an example where professionally, it's multidisciplinary approach to the recognition of domestic violence. And then, in fact, in New Zealand it's the same. So in fact, the New Zealand Veterinary Association has a program as well. And of course, there is quite a body of literature, which I won't go into, on the benefits of companion animals as well, on mental health and other medical problems. So although I focused on infectious disease, because that's my interest, there are other aspects of One Health as well. And lastly, I thought I'd just tell you a little bit about what we're trying to do in New Zealand with the One Health. And we have an initiative we're calling One Health Aotearoa. And it's really based around a collaboration between the veterinary school at Massey and Otago Medical School. In New Zealand we have one veterinary school, and it's a fantastic veterinary school. It's in the top 15 in the world. It's the only one in the Southern Hemisphere that's a reference centre for their World Health Organization equivalent. But it's unusual in the world that the veterinary schools are a university that doesn't have a medical school. So we don't have those opportunities to interact like many others around the world, which is crazy. And so we are, at the moment, trying to build that collaboration. I've got a photograph of my partner in crime there, Nigel French, who's a professor of veterinary public health and food safety at Massey. And we're trying to lead an initiative based around a collaboration between our two institutions, but not exclusive to that. So in fact, we are trying to engage all stakeholders around New Zealand, Crown Research, enterprises, the various government agencies, other organisations that are interested in the One Health concept. And we've started by a number of joint projects, and they don't just relate around zoonosis. There's actually some very generic skill sets that we each have that actually getting together and talking about things. And we were able to work together very well. So in fact, Nigel's involved in a project that has nothing to do with animals. It's to do with the transmission of staph among school children, but he's an expert in modelling how transmission occurs. And so it's not just about zoonosis. We've organised joint meetings and regular visits between the campus and high-level engagement and sharing of that expertise, and also getting involved in teaching and learning. So I have an adjunct position at Massey, and Nigel has an adjunct position at Otago, and we're trying to get involved in each other's teaching programs. And we also here have our first vet and academic. So Pippa Scott joined our group a couple of years ago. She's a vet who's trained in human epidemiology and has been a real asset to us, both in understanding the human side and the animal side. So she is very important in our aspirations. And we had a few people here, I know recognise were at that meeting, but we had a meeting a couple of weeks ago in Wellington, which we organised relatively late. Nigel and I were busy with other things on a shoestring, and we managed to get over 170 people very quickly in a very short time to come along for virtually the whole duration of a 2-day meeting. People from about 45 different institutions, and purposely located in Wellington to get government agencies along, from very high level representation from Ministry of Primary Industry and Ministry of Health and other agencies. A highly, highly successful meeting that really underscored the interest in the country and the need for that sort of networking opportunity. And so we're going to plan to run this as an annual activity. And just to get an extraordinary range of presentations in one place was unprecedented in my career. And also talk about the education aspect. And the Massey group have done amazing. They've got an amazing program in South Asia, funded by the World Bank and the European Commission. The European Community. They in these countries in South Asia, shown on the map here, have got a program of training vets and medical doctors in public health and epidemiology and outbreak control. And the program, and this is, they get through it, they get a Massey master's degree, a lot of it's done by distance learning with projects based in their home countries, and it's a highly, highly successful program. And I had the chance a few weeks ago to visit some of these trainees, and sorry about the poor photograph, but obviously they're 5 of the brightest, most engaging students I've ever encountered. And these are young Nepali students. 3 of them are vets, one's a biotechnology background, one's a doctor, and they've been trained through this Massey program. And I learned another thing about Massey is they have their own time zone. So this was in one of the study offices there where they were keeping in touch with their mentors back in New Zealand. And then just to finish, there are obviously some areas where that One Health approach can be useful, and just do some more topical issues. The Yersinia, that may or may not have been linked to lettuce, and the controversy around that. That was a good example where One Health approach is useful in outbreak investigation. The whole business about what wasn't botulism in the end in Frontier, engagement of early engagement of the right expertise within the sort of One Health group probably would have prevented all of that. And then obviously there's a lot of ongoing issues about dairy as well, and farming as well. That One Health approach would be useful. And I thought just one political commentary to end. This is, you may have seen this in the press, I think it was Friday. Tony Kettle, a professor in my department here, he was actually home unwell, but he was prompted to write this from our Prime Minister, stating that why haven't we got the agricultural Harvard in New Zealand?
Brilliant.
And it was a wonderful piece where Tony pointed out that you need the investment in it. Well, I think we actually have the same for One Health. I think we were in a really interesting position, and not unique, but close to unique position with our reliance on primary produce and fantastic veterinary school and a great medical school and a country that can get on and do things. And it has a global reach within the One Health arena as well, something that can be quite special. So I'm going to finish there. I just have to acknowledge I'm always the danger of not forgetting people. Well, this is the core group that I work with on One Health, and mainly from Massey and Otago universities. So I'm happy to answer any questions.
Questions or comments for David? Gabby?
Is there a potential worry that the animals that are deemed to be the sources or the containers of some of these diseases, say in Africa, would be targeted? I'm thinking particularly of primates and things like that, by the uninformed.
Oh, I think that's absolutely right. Yes, and I think that has happened actually in certain areas. I mean, a lot of the terrain is where the reservoirs remain are really tough, and it'll be. But I think that has happened. Eradication is certainly. I think primates in some areas have been endangered. But a lot of the efforts, obviously, can probably best be focused on how those interactions with humans occur. Perhaps not eating would be a good, but there are obviously cultural aspects. fact, I was at a meeting in Geneva about the whole response to Ebola outbreak, and one of the key lessons that came is you need social anthropologists early. So in fact, to get people, the social scientists in early to actually be able to deal with some of these, not late, which tends to happen. You try and solve them and you realise you need people to understand the cultural issues to put in these interventions. And so actually the social science is really important.
Just curious, I was struck with an antibiotic-resistant pneumonia, Klebsiella pneumoniae a while ago, and there was a lot about it in the paper, and it honestly sounded as though we were all going to drop down dead. Don't hear a thing these days. What's happening with Klebsiella pneumoniae?
We are still worried about it, and in fact it's, as a bacteria, that is one that has acquired a lot of resistance, and particularly strains that have come from the Indian subcontinent. So in actual fact, there's a very high prevalence of those bacteria, so in the Indian subcontinent, becoming unwell.
I had not been out of the country.
No, I know that, but there's a concern because of that situation where it might, with people's travel, where those really resistant organisms may be introduced. So we still see them, we watch out for them, we fortunately don't see large numbers of them, and we haven't had certainly any in Christchurch that have been totally resistant to antibiotics where other places have. But we are worried about it. You don't all need to be overly, lose sleep over it, but we do. And so it's still, it is still there, but the numbers are not great in New Zealand at the moment.
David, you mentioned emerging diseases. To what extent do you think some of these diseases we hear about now are actually emerging, or is it the communication of them through travel and hearing more about them, getting more media coverage?
I think it's all of those. And in fact, the term emerging, it's being used as a kind of, there's now there's journals called Emerging Infectious Diseases, and people use it to get their research funding and all the rest, and there are departments of it and all the rest. But these infections have been emerging and re-emerging forever. And so I think we just have, what we're seeing is a mixture of all of the above. Ones we just haven't seen before, but they've always been there. Ones we would have never heard about, but the communication is such that we're able to hear about it. And there are some that are truly new. So I think it really is a mixture of all of those. The big message is things are changing, and we're seeing new infections come and go, and some more serious than others. And we need to be nimble. And in fact, one of the main messages from that meeting I went to was actually we need to be quite different in our approach. We need to have good leadership, we need to involve a lot more disciplines, we need to be faster in other ways and be flexible and all the rest. So in fact, it's really changing the way that we approach as a wider community.
You didn't mention drug-resistant tuberculosis.
I could have. I guess I was focusing and
Maybe repeat the question slightly.
Sure, yes. The question was about drug-resistant tuberculosis. I'm concerned about that. I guess I was mainly focusing on the links with animals, and of course there is a link to animals for some types of tuberculosis, but the more common one is very much human-to-human transmission, and there is a big concern around the world about the emergence of resistance and tuberculosis that's resistant to all antibiotics. Now, if I can just go on a slight tangent on tuberculosis, there is a particular issue, another issue in New Zealand with tuberculosis, the so-called bovine tuberculosis, the species that is more linked to cattle. And that's one that does cause problems in New Zealand. And it's actually probably spread by our good Australian imports, the brush-tailed possum, which doesn't happen in Australia, it happens in New Zealand. So that's a particular issue. Occasionally causes human disease, more commonly causes livestock disease. And the problem is that's one of the problems with the possums.
Do we know why there isn't that possum
cattle link in Australia?
Yeah, I've asked a lot of people that, and I think it's the answer that comes back, which is only partially acceptable, is I think there is a closer contact in New Zealand with cattle and possum supposedly, but I'm just not sure that explains it all. There's clearly differences because it is interesting, and it's a protected animal in Australia, of course.
Yes. Yes, I just wondered if they had healthy opossums.
No, I think there is something to do with the nature of the contact and how frequently the possum would come in contact with the cattle beast.
I'll fire you a curly one. Where does para-yellow fever come from?
Para-yellow fever. Well, I've never heard of the term para-yellow fever.
I carry it. I got it from a contaminated shot in the army in '72. I can't pass it on, but I can't give blood because that will pass it on. It's a pest, it's a considerable nuisance.
It's probably got another name that I
The
might
medicos in the UK refer to it as para-yellow fever. It has all the symptoms.
of yellow fever.
Stain, your sweat staining things, and so on.
Oh, sorry.
Cycling fever in initial parts.
Right, I will look it up.
I've never managed to find out very much about it.
Right, very interesting.
But I've had it since '72, and they told me it would burn its way out in a few years.
Right,
It hasn't.
okay.
Liz?
What are your thoughts about potential climate change and the vectors that we have to use?
Yeah, so the question was about climate change and how the vectors for these infections may change, and that's been a subject of considerable interest because the range of particularly mosquitoes is often determined by temperature. So at the moment we're just off the mark, for some of these potential vectors, we're just outside the ideal temperature range, but it won't take much warming before there will be some parts of New Zealand where an encroaching mosquito may be able to survive and breed and establish itself. So therefore there would be a risk of, so Aedes aegypti, actually the other Aedes albopictus, the mosquito, that's one of the potential vectors of dengue and Zika, could become established. And of course these are ones that have been found with the surveillance around the airports and ported and various. So some have arrived here but haven't survived. But it is a big concern.
You mentioned when you talked, we're using less antibiotics for feeding animals for growth. Are we doing enough yet, and what more needs to be done?
Yeah, probably not. I gather it's much less than used to. I mean, the quantities are truly industrial. The amounts of antibiotics that we use, there's sort of growth supplements. And, my understanding is that cleaned up the rate a lot, but I think there's still more to do from what the vets say. So there are, and there are huge efforts to be responsible in that regard. New Zealand's clean green images is something they focus on, and clearly it hasn't been for a lot of the past few years.
It's involved in the process of pretty exciting. Here's some foreign thing where you see it sitting in sort of health system.
Right.
And the tension they go with that. And also the way that the WHO contribute.
Yeah.
Maybe the learnings from all the One Health entities. It's just that picture in mind.
Yeah. Well, so the question was about where One Health, like the one key question Kiki was about One Health, where it's set with government, in the countries. Well, it's interesting because Stephen Joyce knows the term, so that's a start, and it's actually making it, and so our conference in Wellington, which we'll always have in Wellington, we invited people to come and address certain issues, and they heard One Health hundreds of times, so there are efforts to actually make the concept better known. In the infectious diseases world, communicable disease, we have very, very poor leadership in New Zealand centrally, very, very poor, and there's a void there that we are actually hoping to fill in a way by showing. In fact, it happened in the UK. A lot of issues around antibiotic resistance and communicable diseases things only really happened when some good leadership was shown by academics who stood up and said, actually, this needs to change in a very positive way. They kind of filled that gap for a while until things picked up. And that's actually the way that Nigel and I view it in New Zealand at the moment. So, we want to have regular meetings with key stakeholders as part of that too, right? And advocacy role, and in a very positive way, be in their face about it, because there's actually this wonderful expertise in the country, and people to get on, and we should be able to deal with some of these issues really quickly rather than have some of the issues that we've been having have shown in the talk. So I think that's where what we're planning to do at the moment, but it's getting the interest. I mean, we're totally blown away by the engagement at that symposium. And I think we just have to keep the momentum going.
Maybe last question.
I'm curious about what your vision is of the best case future infectious disease, if complete eradication is allowable, and what is with good one half of the government, like what would you imagine is possible?
I think complete eradication is very, very unlikely. As you know, but there are a number of. I think what we'll see we will see a number of diseases we will be able to eradicate, and there are some. So we've eradicated smallpox. We've eradicated one of the 4 strains of polio already. So there are 2 successes through vaccination. There are certain ways that make them easier to eradicate. Some are very difficult to eradicate, but there are others on that list. Measles, we should be able to. A number of others. So there will be some that will be able to do that. Others will be mainly controlled. But I think what we'll also see is the way we respond to new infectious diseases will be a little bit more nimble, and the way we actually deal with things is a bit more holistic. So I think the approach will be different, I think. But to think that it's gone, I mean, there's so many different infectious diseases. So some, they're very, very different, and some are impossible to eradicate. We just need to have a different approach to them all, but it'll be a different approach.
With that, it's nearly 8 o'clock, and thanks David very much for an excellent talk, and ask you to show your appreciation